I'm Sarah Quinney. I'm a clinical pharmacologist in the Department of Obstetrics and Pharmacology and Gynecology, as well as Division of Clinical Pharmacology at Indiana University School of Medicine. And I'm the lead the Maternal Pediatric Precision and Therapeutics, or Imprint Hub. And I'm pleased to welcome everyone to our Clinical Pharmacology Trainee Network Pediatric Clinical Pharmacology webinar. We again thank you for your patience as we've been navigating this situation. And we are glad that we have so many of you here with us today participating. So today we welcome Dr. Rachel Chevalier from the University of Missouri, Kansas City School of Medicine, where she is a pediatric gastroenterologist in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Children's Mercy in Kansas City. She's going to be talking today about drug absorption and disposition in children with a focus on physiologic changes in the developing digestive tract. We do have the chat available for you. If you have questions, please use it, or we will have time at the end of the webinar for questions and answers. So thank you. And with that, I'll turn it over to Dr. Chevalier.
Hi, thank you so much for having me. So like Dr. Quinney was saying, my name is Rachel Chevalier. I'm in Kansas City. It's been raining here for about 3 days straight. So it's a little dark in my office, but hopefully you can see me enough. I'm a peds GI doc and have been working as an attending for about 8 years here at Kansas City. I have been I have been involved in medication stuff for a long time. I started working in drug delivery in college. As an undergrad, I did my research in fellowship on oral drug delivery of insulin, and have kind of been in that clinical pharmacology space for a long, long time. Though I was telling Dr. Quinney, I am not technically a clinical pharmacologist like many of you. So I am friendlier than I am smart. You are welcome to ask me questions via however you would like through the chat at any time, and I'll do my best to answer them. But otherwise, we'll just get started. So the objectives today, we're going to review some of the developmental changes in the maturing pediatric digestive tract and the relevance to pharmacology. I actually changed a word. I've been moving away from saying gastrointestinal tract to saying digestive tract because it's much more all-encompassing. One of the cool parts about being a GI doc is that you get like 5 organs, right? So we're going to be talking not just about intestines, but about the stomach, the esophagus, the liver, the biliary system, the pancreas. All of that is included in that digestive system. Which is, I think pretty cool. Like, cardiologists, whatever, they get like 1 organ, maybe some blood vessels. We get like 5. So there's a lot that goes into this and a lot of really complicated physiology. We're also going to discuss the influences of diet and disease and the microbiome. So, outside of just those organs and their development in an isolation, how some of those more environmental factors can affect things. And then we'll talk about some clinical examples, identify gaps in knowledge, and basically just try and convince you that looking at pediatric components is a much, much needed field. So overall, some factors influencing oral absorption, these are the areas we're going to go into. One, I'll call pre-stomach factors, just to kind of encompass all of this like oropharyngeal, esophageal area. We'll talk about stomach factors, including like pH, volume, and emptying time, intestinal factors, and then hepatobiliary factors. So hepatobiliary, including, liver, gallbladder, pancreas, and then all of those together, the disease effects that can go along with those too. So this is just a quick, if you're not, don't have at the forefront of your brain what the digestive tract looks like, this is a quick schematic of it. So your digestive tract starts at your mouth and goes all the way down to your anus. You start with your esophagus there at the top, pass into the small intestine, then to the colon. Your liver and pancreas start emptying like biliary juices, digestive enzymes in at the first part of the small intestine in the duodenum. And all of this area is affected by all of these areas can affect some of your oral absorption. So first we'll talk about those pre-stomach factors. If you're not a birder, this is a swallow, and swallowing is the first step to GI absorption. So no drug works unless you take it, and compliance is such a huge part of pediatrics. If any of you have a toddler or have ever worked with a toddler, you know full well that trying to give them something they don't want results in them spitting in your face. But swallowing itself is an interesting concept. So it's an innate reflex in utero, but it does require coordination postnatally to be effective. So you're born knowing how to swallow, but you develop that mechanism a little bit more as you age. So in these pictures, we're sort of looking a little bit at that first part of the swallowing mechanism. So that green junk there is like the food bolus. You have an oral transport phase, an oral preparatory phase where you're preparing for that swallow, a pharyngeal, and then an esophageal phase. And this is all a very complicated process that can be interrupted a lot by different things that happen in your life. So one being immature age, were you born premature and you haven't sort of gotten enough of those skills developed. Maybe you didn't learn these swallowing skills because you were too busy having heart surgery in the first several months of your life, and now you've been NPO for a while and you didn't have the usual trajectory of developing that. So you can start to reject medication or really anything in that oral transport preparatory phase, i.e. just spit it out because it tastes gross. So sensory development and food acceptance, these all change very interestingly in childhood. So you can make some sort of broad generalizations for populations. Obviously, individuals are individuals, but some broad generalizations you can come with. Sweet preference appears to be innate. So babies are born, they like sweet. If you have ever tasted like breast milk or baby formula, it definitely has a really strong sweet taste to it. So those are palatable foods to younger infants and babies. Aversions to bitterness appear from an early age. And then saltiness can be aversive or neutral to infants, but the adult patterns of preference for salt don't tend to show up till about age 2. So as much as we all love salt and everything, babies just aren't as into it. Odors, including like volatile flavors like cherry, a classic medication favorite, which you can like smell and perceive through olfactory ways, don't have as much impact on kids until about age 5. So smells just not as bothersome to them until they're a little bit older, which, you know, makes sense for someone who, you know, essentially poops their pants all the time. Like and they seem unbothered by it. It's probably part of this development of that smell sense. And then young children tend to find strong or irritative sensations in the mouth, like carbonation and pepper, to be aversive. That's not a surprise to anybody who's ever seen a kid take their first sip of like bubbly water when they weren't expecting that. They tend to not like that. They'll spit that out too. So the esophagus, we'll move on to the esophagus. You've swallowed it. Now you've got it like in sort of the food tube, we call it to families, transporting whatever it is you've swallowed, the bolus from your mouth to your stomach. And the esophagus is a challenging environment in general. So it's really designed to be a transport to the stomach, and it's not designed to pick up nutrients or medications or anything like that. And there's really very few times you need to target the esophagus, but when you do, it is very hard. And this is what my research is in, so I care a lot about it, targeting the esophagus for an inflammatory disorder called EoE. And you have all of these components that you have to fight against: saliva-coated, swallowing, and peristalsis. You know, if you have ever taken a really big bite of something and you sort of like feel it travel down and you notice how slow that feels, you know, actual swallowing is usually pretty rapid. Mucosa is not designed for uptake. And then, especially in pediatrics, you get a really variable length. So a very like niche area, but it does have its factors that matter. And then esophageal mucosa actually expresses drug metabolizing enzymes. Not a lot known into like how much that matters, but for drugs that are acting locally, for instance, budesonide that we use for EoE, this may have some component that could be contributing to that medication having its effect. So this is a study we did where we actually just went and looked to see like what DMEs and transporters that have used budesonide as a substrate are present, and 3A4 and PGP not really there, but you do have some 3A5 and a question of whether that's affected by disease, which we'll discuss more later. Okay, so moving on to your stomach. So this picture is just ubiquitous on the internet. And I tried so hard to find like where the origin was, and I just couldn't find it. But people just, for whatever reason, really love to compare baby stuff to like fruits and vegetables and produce. So here it is in stomach form. And basically this is to demonstrate that stomach size changes vastly during that newborn period and in early childhood. Stomach is where your drug dissolution mostly takes place. And so the gastric volume that it contains is going to be really different between a child and an adult. For the volumes in this picture come from a reputable study. So you can see, 5 to 7 milliliters, you're looking at like, a max volume of like a teaspoon and a half in that newborn baby's stomach. For reference, adolescent stomach has a functional volume capacity of about 1,000 milliliters. And you really don't want to fill your stomach to full capacity unless you want to vomit. And you'll puke before you get there just due to like stretching of stomach receptors. So when you have, these young babies, these newborn infants, and these neonates, you're trying to, administer anything orally, you have to be really, really conscious of the volume that you are able to work with. And you're also, a lot of times competing against ability to intake food during a time for rapid growth. All right, so the other problem with infants is whatever you put in has a good chance of also coming back out. I think everyone is very aware that babies spit up. So infants have these underdeveloped gastroesophageal sphincter muscles. So that connection between the esophagus and the stomach, there's like a circular muscle there that closes off so that when your stomach is churning, things don't go the wrong way, they go the other way. And that muscle is not as strong when you are sort of in the first few months of your life. It also decreases with age, which is why when you get older, you get a lot of reflux, but really pretty weak when you first start. So reflux is physiologic in babies, though it probably doesn't feel that way when you're a parent and you feel like they're puking everything they have. But almost half of 4-month-olds will reflux at least once a day. And this says like up to 10% of their feed volume. I've seen studies where it's even higher. So it looks like everything they ate a lot of times. But as for most of us, like as long as they're growing, that's fine. This reflux frequently happens shortly after eating. Medications don't really help. So there are tons of us out here prescribing, H2 blockers and PPIs to infants for reflux, but it almost never decreases the volume that's coming out. Usually that helps with more like altering the frequency and volume that you're putting in. So reflux really peaks at that 4 months of age and usually resolves by a year, but that's a long period of time that you're having to work with that. And infant reflux varies in how it's digested, what comes out basically. What comes out when an infant refluxes varies in how digested it is. So sometimes it looks just kind of like the milk that just went in. Sometimes it's partially digested. And then sometimes like that will change depending on sort of how families are responding to the reflux that's happening. So for some of them, it's more concerning than others, and they'll make bigger changes in like what they're feeding babies and things like that. So then they will be like spacing out feeds differently, changing volumes, all of that can affect, change of volume of food in your stomach when you're trying to administer a medication, for instance. The other thing that you have happening in your stomach that can really affect drug solubility is pH, gastric pH. So some medications require low pH to release, dissolve, or activate. And gastric acid production changes over early childhood development. So the machinery to produce that acid is present at birth, but the pH of the like neonatal stomach tends to be a lot more alkaline than adult. And some of that is due to like frequent feeding. Some of that is probably just due to immature machinery. And exactly how long it takes to get to like below 4 for a pH and stay there is kind of variable, but you can definitely see some differences in different studies of, you know, what that level of acidity is. And also you can see like in this case, like they're producing gastrin, but the stomach is just not responding quite the same as you would with an adult. Okay, so pH also affects stability of medications. And so drugs that are acid labile are going to remain relatively protected in that more alkaline stomach, in the higher pH of baby stomachs. And that can result in a significantly higher circulating drug concentration. So this is a classic example from a study from 1953, looking at penicillin serum concentrations over time. So you can see like in those different hours, you've got your preterm neonate and your full-term neonate up there at the top in the blue and the pink, where they've got a really significantly higher concentration than even like your older children's, your older children a few weeks in. And this is thought a lot to be from this acid stability. Drugs with pH-dependent solubility characteristics and formulations that rely on pH-dependent coatings may exhibit very different disintegration, dissolution, and drug release characteristics at gastric pH values that are higher than those observed in adults. So another thing to consider is that diet content and frequency of feeding changes rapidly in the first year of life and somewhat beyond. So your newborn baby is eating 8 to 12 meals per day. They have that tiny little stomach. They can't put a lot of capacity in there, but they still need a lot of nutrition to be able to support the rapid growth that happens in that newborn period. So they're eating frequently at small volumes. By the time you hit a month, you've decreased that down to about 6 to 8. At 6 months, you're now doing 4 to 6 meals a day. You're sleeping more through the night. So you've got long periods of fasting, and you've also started to eat table foods, which have a different consistency and content. You work your way up to toddler, where you now have like 3 meals, 3 snacks that you're spacing out through the day. And then you hit like adolescence, and like, who even knows? Like, this is my son, this is my preteen here, making shrimp scampi like a fancy man. But I've also seen him eat like an entire jar of pickles in one sitting. And I know he's sneaking Halloween candy in the middle of the night. So a lot of variability in both what and how much is going in there. So this is looking at gastric emptying rates and how they increase with age, although kind of minimally. And you'll see a lot of big differences between, you'll see a lot of these differences come in the like difference between preterm and term infants. So although innervation of the stomach is established at birth, the communication between the nerves and the muscle fibers is immature until about 6 to 24 months of age, resulting in slower gastric emptying in some of those newborns. This means that stomach, like drugs may remain in the stomach a little bit longer. You have more time to interact with stomach contents like food or acid or whatever. And it also means that it can take longer for the drug to reach the primary absorptive site, which is the small intestine. You can also see, which I didn't put this study in, but you can also see a few effects in puberty as well. So all of this has to be factored in when you're thinking about like how long is that medication going to be in there. And then meal type also influences gastric emptying. So we have great evidence that like the more stuff you have in the stomach, the slower it's going to empty, which makes sense. You only have one outlet there. Liquids empty faster than solids. And then high calorie, high fat foods empty slower as well. Variability in gastric emptying is going to affect how long that drug sits in the stomach. So if I eat it with bacon and eggs, it's going to sit in there a different amount of time than if I eat it with just a bottle of Gatorade. And so that's more time to reach the small intestine, more time in potentially like an acidic environment. etc. And so this graph here really just highlights those differences with different types of meals. So aqueous, breast milk, and formula. And breast milk and formula have enough difference in their components that they are treated very differently. Breast milk, a lot of times in pediatrics, for things like gastric emptying, for things like surgery preparation, is treated more like an aqueous an aqueous thing. So, you can have clear liquid, for instance, you can have clear liquids and breast milk up to 2 hours before surgery, but you have to stop formula 4 hours before. So there's differences in those compositions as well. Okay, moving on from stomach to intestines. So infant intestinal motility changes with gestational age. So your small intestine is moving to form peristalsis, to move things through pretty much all the time, but with different amplitude, strength, and frequency, depending on sort of where you are in a fed fasting state. But you can also see some differences in things like prematurity. So babies in general have more erratic and less effective muscle contractions in their small intestine. And then this study was done using like a nasal, sensor, like a nasal manometry sensor that went down into the duodenum for these neonates in the ICU. And they found that, especially like in the preterm infants, you have more incomplete digestive cycles. So you kind of see this like cyclical nature in like these motility tracings, these pressure tracings. And with the younger age infants, you're seeing them be less coordinated, which is going to give you less of that peristaltic push to move things through the small intestine. All right, so they have done some other studies, some scintigraphic studies to look at basically how long does it take for something to go from like mouth to cecum. So the cecum is the very first part of the large intestine. So your food bolus or whatever travels all the way through, the upper GI tract through the small intestine. There's a valve at the end of your small intestine called the ileocecal valve. Everything passes through that, and then it sort of starts to pool a little bit in your cecum. So you can get kind of a good idea of like, you can get enough signal in that cecum to get an idea of, okay, that's how long it took to get there. So these studies were done looking at, cecal activity on radiographic studies. They found that time that it took for adults was like 2.8 hours, oral to cecal transit time. For preterm infants of about like a gestational age of around 28 weeks, which is pretty small. They found that it was even slower, and probably some of this has to do with those immature non-propagating contractions that are just a little too erratic, a little too weak to be able to move things through. So you're seeing some differences in how things are actually moving through the GI tract. A lot of studies doing a lot of this comparison just don't exist. It's really hard to study neonates. No one wants to be sticking catheters into preterm babies, putting them at risk for things like necrotizing enterocolitis. So we only have a few things out there, but when you do find them, they're always sort of interesting. So this slower GI tract transit has been shown in studies to increase medication Tmax. So this one was done with cisapride by Dr. Kearns, and this is looking at different babies, different post-conceptional ages. So that's like your week's gestation essentially, but including like, have been born and have lived for a while. So babies that are post-conceptional age, 30 weeks may have been born at 28 and are now 2 weeks old, that kind of thing. But essentially, like the younger your post-conceptional age, the lower you, like the further back in development you would anticipate, the longer you're going to see that, or sorry, the higher that Tmax is going to be. So you're seeing an increase in that amount of time. And then the other thing that can change is absorptive surface area and efficacy of the intestines. So You know, obviously, just like every other organ in your body, you have a lot of development of your intestines through the time of conception up until time of birth. And the absorptive capacity of the small intestine resides in the villi and the microvilli. So those like bumpy looking fingery things that you see over there, those are the villi. And then sitting on top of them are what are called the microvilli, which looks like sort of a microscopic version of that. So you got fingers on fingers. So overall, earlier earlier in development villi are not as good at absorbing small molecules. But they are better, especially like newborn infants, at absorbing large molecules, which is sort of how immunoglobulins pass into like from the mom, from that breast milk into the infant's body. But they're not as good at picking up those small things. And some of that is thought to be, just due to surface area. So for a long time, we thought, shorter intestinal length in children accounts for decreased intestinal absorptive surface area. Sure. But intestinal length isn't quite the full story, because when you look at the relative pace of intestinal length growth, then we actually see that it approaches adult values much quicker than some of the other anthropometric parameters. So, this here, like body weight, surface area. So like if you look at a 1-year-old, their body weight and body surface area are about a third of an adult, but their intestinal length and surface area is a little bit closer to like 70%. So if it's not just the size of the area, the available space that you have to go and figure out like what's going to absorb what, then there must be some other characteristics that contribute. So we now see that there's some maturation of the villi themselves, and not just the length, that contribute to this increased absorptive area. And this changes, and this is all in the small intestine, and changes as the child grows and develops. So in that picture that's kind of right in the middle, you can see like the picture from an endoscopy. This is kind of what a small intestine looks like in like a normal developed small intestine. You see all these like floating wormy shag carpet, however you want to describe it, villi sticking out that we think of it like reach in, have a lot of surface area that allow those nutrients or medications or xenophilic, whatever it is that's out there, to be picked up. So then there's sort of two components to villi like this. There's hold on, okay, there's the villi themselves, and then there's the crypts. So that H&E stain right below the picture is sort of demonstrating that. So the villi are the part that are sticking up. You can see those in the endoscopy picture. The crypts are the part that's kind of going down. That's where stem cells are located. That's where the development of those enterocytes that go up the villi are present as well. And both height of villi and like depth of crypt change with size and characteristics as kids age. So both of those things are important components to growth of the enterocytes, as well as ability to produce enzymes and pick things up. And then those villi sort of change how they look and appear through time as well. So the pictures on the far right, on the top, you see the adult villi, which look like these finger-like things that sort of stick out. And then the villi in an infant, which are down below, are more ridge-like. So they're more of like a, continuous wall kind of going on versus like individual projections. And so you can think that's probably going to change surface area and is also just not equivalent. So I mentioned this a little bit before. So additional factors that account for differences in absorption early on are related to immature tight junctions in the pediatric small intestine. So your enterocytes that line the epithelium in your intestine have to sit close to each other. They have really tight intercell permeability, so that all of the garbage that you put in your mouth every day doesn't all immediately go into your bloodstream. So those tight junctions are a little bit looser in early infancy, which makes it easier for large molecules and antibodies to be absorbed. So this is how babies get those immunoglobulins that are protective against disease, protective against infection from breast milk. And this increased permeability goes away with age as the tight junctions mature.
So this is a graph where they used radio-labeled alpha-lactoalbumin given to infants just to sort of demonstrate this principle that, you know, you have a lot more passage of those macromolecules sort of the younger you are, and then as you get towards a few months old, that starts to decrease. So in neonatal age, and particularly in the case of prematurity, a considerable part of dietary fat is not absorbed from the intestine and is just excreted via the feces. So fat absorption requires digestion, requires lipolysis, lipolytic enzymes, and then subsequent intestinal absorption of the hydrolyzed fatty acids. And part of the reason for this relative fat malabsorption that you see in infancy is just due to this decreased pool of bile acids. So bile acid synthesis is reduced. The bile delivery from the gallbladder to the intestine is also decreased just because the biliary canaliculi are not done forming. And so basically, like the liver is too immature to make enough bile to help sweep up all the fat-soluble things, including vitamins, fat-soluble vitamins. And so this is why we supplement fat-soluble vitamins to babies in the NICU and the nursery. So a lot of babies out there, the general recommendation is that all babies everywhere, if you're being breastfed, be supplemented with vitamin D. And then this graph here just kind of shows some of that change in those bile acids as time goes on. So another reason for possible fat malabsorption is pancreatic lipase abundance or lack of. So infants are labeled as sort of having this like physiologic steatorrhea. So physiologic fatty diarrhea in the first 3 to 6 months of postnatal life, just since overall lipase output is like 5 to 10% of adult values. So you anticipate that infants are going to be losing a lot more of their dietary fat in their stool, just as like a percentage, than adults are. So this is a study sort of demonstrating this, and the 3 different conditions that they're showing here, I know it's hard to read, are basal, and then they used sort of 2 different stimulating medications given to the babies to try and stimulate lipase production. And basically it shows that, the difference between a neonate at 1 month and a 2-year-old is pretty significant in terms of how much lipase or amylase they're making. So this is what's contributing to that, high fat loss in the stool. It's all physiologic, and our bodies and our neonatal diet accounts for that. But when you're trying to work with like lipophilic drugs, for instance, they may demonstrate some capacity limited absorption in these pediatric patients. And especially when you compare them to like older children or adults. So one example is placlaronil, which is like an antiretroviral, and they did these dose escalation studies in adults and pediatrics. So that graph on the right, just for reference, the pediatric patients were given a 5 milligram per kilogram dose. In the adult study, they're obviously given, different fixed doses. And if you sort of put all this data together as a comparison, then you find that like a 5 milligram per kilogram dose for children sort of equivalent is mostly equivalent to like a 3 milligram per kilogram dose for those adult patients. So it's not just, body size related, at least not weight related. So the intestinal mucosa itself contributes to metabolism before those drugs even reach the systemic circulation. So we're talking a lot about like, measuring serum levels and that sort of thing for medications. But there is potentially, there's a step happening between when it's in the lumen of the intestine and when it's actually reaching that serum. So there's digestive enzymes in the intestinal mucosa, there's nutrient transporters, and then there's drug metabolizing enzymes in addition to the digestive ones. There's a lot happening like really at that interface between outside world and bloodstream. So this really is just to demonstrate like the intestinal epithelium contains so many different drug metabolizing enzymes at different concentrations, and a lot of transporters as well, both efflux and influx. And then this intestinal expression of drug metabolizing
enzymes changes with age as well. So this is looking at this study here, looking at 3A4 activity, and so total protein and then activity via conversion of testosterone to 6-beta hydroxytestosterone. So these were duodenal biopsies and surgical sections that were collected from like 100 pediatric patients between 2 weeks and 17 years, and then 11 fetuses. And you find this statistically significant increase in CYP3A4 expression and activity with age. And it's practically absent in the fetal duodenum, but is expressed at relatively low levels in neonates. And then as you get up to children about 5 years of age, you start to see that increase toward adult levels. So this study went and looked at other enzyme activity in the pediatric intestinal biopsies. So one thing to note is I combine these into one graph just for ease of seeing it. So some of these are in picomole, some of these are in nanomole. Don't like directly compare, but this is more just to look at how they sort of vary with age. So that AHH, the aryl hydrocarbon hydroxylase is sort of the one that you might see some age variations with, where things like epoxide hydroxylase and glutathione peroxidase seem to kind of not have too much age change or dependency, although it's not super strong data. And this is another study sort of looking at glutathione S transferase activity, and shows some level of waning with age here by looking at busulfan. So because these children, because younger children may have higher activity, they might clear the chemotherapy, their chemotherapy a bit faster, which is, achieving those ideal levels is pretty important when you're talking about treating cancer. So having variations there with age can be important. So intestinal transporters don't seem to show like one single developmental pattern. They kind of all do their different things. And I think there's definitely a lot that people are still trying to figure out about this. But we'll go through a couple of examples of some things that have been shown. So first is looking at the efficacy of iron transport via DMT1 and how that increases with age. So on the left side, we're looking at, this is from mouse experiments, and we see the DMT1 expression is these little black dots. So in the one that says GD, so gestational day 18.5, you see these little black dots on this IHC staining that are basically the DMT1 is in intracellular vesicles. And then as PD is postnatal day, so as the mouse ages from postnatal day 0 to postnatal day 5, then you start to see more of this dark staining show up. So that DMT1 is moving more into the intestinal tissue, more into the, apical membrane, more to where it should be. The study on the right is looking at enteral iron absorption based on age. And you can see here also, so iron being a substrate for DMT1, as patients age, you tend to see, you see more of this enteral iron absorption. So we've got mouse studies looking at DMT1 location. We've got human studies looking at percentage of enteral iron absorption. Honestly, in general, neonatal hemoglobin physiology is really interesting. In neonatal life, iron absorption is more dependent on lactoferrin pathways. Iron hemostasis is poorly regulated. It's this whole thing that's very complicated and cool. If you're ever interested in learning more about that. So here's some more looking at transporters. So here, this study is looking at MRP2 and BCRP, which show some increased protein expression with age as well. So this study was done using leftover surgical specimens from jejunum and ileum, and then doing quantitative proteomics. This was like 58 children, 16 adults, and just sort of show that like infants have this lower quantities of MRP2 compared with adults.
which can matter for medications like azithromycin, ampicillin, ceftriaxone, all substrates for MRP2. And then BCRP, also abundance increasing with age. And that's some substrates for that: methotrexate, apixaban, chemotherapeutics, all of these things that we use in pediatrics. I'm always a little bit wary of pediatric leftover surgical studies, only because most kids, most all kids are not having parts of their small intestine removed because they were doing great. So if it's due to like an accident, sure, but a lot of times pediatric patients are having intestines removed for like complications of prematurity, or like genetic defects that may also take a play into this. But still, 58 children is a pretty good age range, and I thought that was good, or a pretty good range, and I thought that was good. So just going back to this concept of, that like we eat different things at different times in our life, age-appropriate diets can contain components that alter exposure as well. So this study was done in 1992, and I would bet that apple juice consumption is actually different now because, the AAP and everybody has kind of changed their recommendations in terms of like sugary juice consumption, sugary beverage consumption in general for pediatrics. But I still think it's probably true that the, amount of apple juice consumption at age 1 is vastly different than the apple juice consumption at age 40. Kids like apple juice and are given apple juice much more often than adults are. But, I circled there, 1992. But apple juice itself competes with fexofenadine for OATP transport, for instance. So here in this study, they gave patients apple juice and then Allegra, both of which are substrates for OATP. And then you can see that the plasma concentration of fexofenadine is affected by having that apple juice in there. And so depending on, I think it's pretty known probably by this point that like to you, like that what you eat can affect some of those medications, but you can see those changes even like across a population, pediatric diet being different than adult diet, unless you're one of those people who only eats chicken nuggets and goldfish crackers as an adult. Otherwise, probably have a varied diet from a toddler. All right, so next we're going to talk a little bit about liver. So this picture with this baby that's seen some stuff is really just to demonstrate that hepatic drug metabolizing enzymes increase with age generally, but at like sort of different rates all the way until they get to adult levels. And so CYP3A7 is the predominant CYP isoform expressed in fetal liver. This peaks shortly after birth and then rapidly declines. Within hours after birth, CYP2E1 activity surges and CYP2D6 becomes detectable sort of soon after that. CYP3A4 and CYP2Cs become, you see them in like the first week or so. CYP1A2 doesn't appear till 1 to 3 months of life. So, and then overall, like this percentage of adult activity changes with time and not at like a specific linear rate relative to each other. Some other things that change are liver size increases with age and varies with sex and body habitus. So here's 2 different studies looking on the left, at liver span in children, males with a slightly bigger liver than females, showing that increase, and then liver volume in variation with weight, including normal, overweight, and obese. And these kids don't. Oh, I should have put a picture of like a growth chart in, but kids don't grow linearly over time. You probably have heard of like growth spurts and things like that. And those can vary between kids. So like when they're having those changes and everything. So kids have very different, very varying rates of growth. And even when we're trying to keep up with medications by weight-based dosing and things like that, they require frequent dose changes for medications. And part of this is just the general size of their body growth and how that varies. All right, so next we're going to talk about the colon.
This is Christian Cologne from the 2005 Royals World Series team, who was kind of like a backup outfielder, I think, but had like 2 really big deal hits that helped them win the series. I have his jersey because it says colon, and that's fun. But he's a great player. Now is the hitting coach for the Monarchs. But we don't always think of the colon as relevant to like drug absorption and distribution. There's a lot of focus on that small intestine. But I'm a GI doc, so I use medications that target the colon specifically to treat things like inflammatory bowel disease, where that's the site of the inflammation. We're going to use something essentially topically to get to that area. Sometimes you're doing that rectally, sometimes you're doing that orally. We also use rectally administered medications not infrequently in babies, especially ones that have difficulty with that oral motor control. So when we're talking about colon, then you've got to think about when we're talking about colon and you're thinking about how it moves differently than your small intestine. So when I talked earlier about like your small intestine is kind of moving, although with different speed and intensity all throughout the day, depending on fast fed state, your colon does these high amplitude propagated contractions less frequently. And you want this because otherwise you would be just like pooping all the time. So your colon or a bowel movement happens not nearly as many times per day, though it does have some range for people. So those squeezes that you feel that move stool along the colon into your rectum, those are your high amplitude propagated contractions, your HAPCs. So this graph shows the number of HAPCs as a variation of age. And basically in both a fasting and a fed state, basically showing you that like babies are moving stuff through much more frequently than you are as you get older. So there's, in addition to like that frequency of movement, there's also, like learned, like anal control. So rectal stretching of the internal anal sphincter is what gives you the signal to go to the bathroom. That's what says you need to go now. And then relaxation of the external anal sphincter is what allows you to pass stool into the toilet. Eating sends hormonal signals down to the colon to basically like move the old stuff out. So when you eat, you get a lot of hormonal signals down into the colon. You can start getting these high amplitude propagated contractions. So you may be a person or know a person who basically has to like poop as soon as they start eating. Sometimes people feel like, oh my gosh, like my food just moves right through me. But really it's just like a slightly exaggerated version of like a normal physiologic response. Now, people with IBS sometimes get like a really strong response. They have to go to the bathroom really pronto. That's not ideal, but there is some level of physiology in there as well. Okay, so why does this actually matter? So let's talk about like suppository bioavailability can be affected by developmental age. Is this due to those high amplitude propagated contractions? Is this due to immature epithelium? Is it both? Who knows? But you definitely see some changes both with Tylenol and erythromycin in what in like what exposure those patients are seeing. And so, yeah. Okay. So let's move on. Sort of like the last section is to talk about the microbiome, or I have 2 more sections, microbiome and disease. So first we have drug-bug interactions. So your bacterial diversity changes drastically with age and development, including early childhood, which makes sense. You are you're developed in a very different environment than when you go and live. You get all of this exposure. All of your bacterial diversity is very limited, and then it becomes much different as you get older. Not a particularly surprising concept. But some of the other things we know about microbiome is that like your intestinal bacteria can activate medication. So sulfasalazine needs certain colonic bacteria to be able to convert a prodrug into an active form in the colon. And we use sulfasalazine to treat like inflammatory bowel disease. So it's where it's getting activated is the site of intended effect. Another example is irinotecan. So intestinal bacteria expressing the beta glucuronidase gene can sort of deconjugate this.
and then allow it to go back to systemic circulation, increase its duration of action. So basically bacteria, and certain bacteria, not just any, but certain bacteria have to be present in order for these effects to happen. And depending on where you are in that developmental cycle, you may or may not have adequate amounts of those. Intestinal microbiota also affects host drug metabolism. So this is a mouse study looking at mRNA expression for CYP3A11, CYP4A14. They did some other ones as well. They also showed that CYP3A11 protein is decreased. And the mechanism here is unknown, but since like CYP3A11 is a target gene for like PXR, it may be that intestinal microbiota need intestinal microbiota make a ligand for PXR. So no microbiota means no ligand, which means no PXR activation, and then maybe no CYP3A11. Possible explanation. The authors of this study also postulated that like some of that variability of expression of CYP3A4 in like regular adults might be due to differences in the intestinal microbiome as well. So this is a big, good study, and I know it's like impossible to read, so I highly recommend if you're into microbiome stuff to go look at it. But essentially, this is a get the idea of the color from a 20-foot view type of situation. So they went and looked at 271 drugs tested in these colonic bacterial cultures grown from mice. And about 2/3 of the tested medications were metabolized by at least one strain of colonic bacteria. So this is basically just showing that like those bacteria are probably contributing to a lot of what's happening, at least as far as medications that are still in a decent concentration by the time they get to the colon. And for, like GI doctors, that's ones that really matter to us. All right, so impact of disease. So intestinal inflammation disrupts the mucosal integrity, enzyme production, all kinds of stuff that your intestines do. So here's some endoscopic pictures. On the left, in the yellow box, is normal. If you look closely, you can see those villi that I kept showing you earlier. And then the pictures on the right are showing sort of some ways that you can visually, macroscopically, grossly see changes in the intestinal epithelium. The top one, you can kind of see those little divots. That's scalloping, where parts of the intestinal mucosa have been like eroded away. And then you probably don't need to be a GI doctor to know that that bottom picture is like a disastrous nightmare. So that white stuff is pus. There's erythema, it's edematous, the whole lumen is narrowed, it looks bad. And that mucosa is not functioning in all the ways that we've already talked about. Like all of the stuff that's sitting in that epithelium is gone because that epithelium is gone. So this is a study where they went and looked at intestinal inflammation in celiac disease and its effects on CYP3A4, and then again, like the functional study of CYP3A4. So you have celiac patients, non-celiac patients, and then treated celiac patients. And essentially what you're seeing is that, when you have celiac disease and that epithelial mucosa is disrupted, it's eroded, it's not doing well, you have a decrease in the amount of CYP3A4 that you're producing, but it's recoverable if you then undergo treatment for celiac disease and recover that intestinal integrity. Okay, villus length as a measure of like intestinal inflammation also can predict CYP3A4 expression in the duodenum. So if you remember the H&E stains we showed before with the villi and the crypts, when you have disease that's affecting your intestinal epithelium, one of the things that you start to see is a flattening of those villi. So rather than having all the fingers that stick up, they start to get like nubbier and nubbier and nubbier until it's almost just flat, as that like top layer, that epithelium kind of gets eroded and messed up. So here, this study they're actually just measuring like the length of the villi in Crohn's disease, which is something that causes, erosions and loss of that intestinal epithelial integrity. And comparing it between how much CYP3A4 that you're seeing, and basically just demonstrating that, as your villus length decreases, you're seeing less production of CYP3A4 in that epithelium. Okay, so This lecture is definitely not comprehensive, and really I just want to highlight some known and or potential differences in pediatric and adult populations. Pediatrics is full of small studies, and like we know that's from like the clinical world, that where you see it, but you just can't get a big enough RCT to prove it. And we don't always have the big data to back them up. So, use your clinical knowledge and your clinical colleagues, find out all of the whys so that, we can provide better care to babies and kids. Another thing is, a lot of these differences I show are in that very neonatal life, or a difference between preterm and term, which is a very short period of life, admittedly, but also a very critical period of life. So never discount the fact if you have a baby that needs medication in the first however many months of its life, that medication is going to be pretty vital. So being able to make sure that it is the most efficacious and has all of those precision medicine parts to it is very, very important. So take-home messages, vast differences in GI physiology in infants versus adult, as far as things like gastric emptying, stomach volume, pH, et cetera, et cetera. A lot of these differences are a bigger deal in preterm babies. Not all 1-week-old babies are the same. Your intestinal SIPs and transporters are affected by age, and not just in your liver, but in your intestine, potentially in your esophagus, other places as well. Different parts of the GI tract mature at different rates, making like the age of adult GI tract maturity difficult to pinpoint. Your liver, it matures at a different rate than your intestine, than your pancreas, than your esophagus. And then what you are able to do as terms of like whole body development is different as well. You are safe to swallow pills at 6 to 7 years of age, but certainly not all kids can. And then for precision medicine, consider organ physiology, but also disease effect, and how all of those components go into it. So that's all I've got. I have to thank all of the people who helped do my studies, all my work, all the people at work, all the GI doctors, and everyone who helps teach, care for, and feed my children so that I can make presentations and give presentations like this.
Great. Thank you, Rachel. It was very, very informative. There's a lot of changes we need to account for in pediatric patients, and I think you covered several of them, and to allow us to see that with respect to drug absorption. We do have a couple of questions in the Q&A. The first, is there a database available that shows various drug transporter expression changes in ontogeny with age, maturation, and/or development?
Ooh. Good question. I mean, I know there's components of that in a lot of databases. As far as like one central, I would have to ask one of my colleagues.
Okay.
I tend to get into my one little area a little bit.
And then I guess the other related question, which you may also need to ask a colleague for, is are there animal models that have a close representation of humans to understand transporter ontogeny?
So that's probably going to be a little bit specific to the transporter, of which there are many. And there's lots of models of like intestinal development in a lot of different animals. I know in particular about like pigs, because that's a little bit of what I work with, but those what enzymes and what transporters are present and are expressed are not always equivalent to like what's in humans. So you're sort of working with two problems when you're trying to develop good models for things. Is one, is the animal model producing the transporter or whatever that you're interested in? And then also, does their developmental cycle mimic enough of of a human to replicate what you're looking for? So complicated answer is maybe, but it probably depends more specifically on what you're looking at.
And then another question, would you address the oral absorption of monoclonal antibodies?
So yes, so the oral absorption of monoclonal antibodies is something that we would all love to have, and is just not great is not like, just it's not there, right? Like there's differences in uptake. There's also differences. There's problems with stability. Like I use monoclonal antibodies all the time in inflammatory bowel disease, and EOE. So I am on the regular prescribing injection and infusion medications to children. And there's nothing I would love more than to be able to switch that over to oral medications. So I know every once in a while I'm like deep diving literature to see what's out there and what's happening. Definitely nothing that's come even close to prime time yet. And I know, at least from like back when I was a fellow and I looked more into this when I was working on like oral biologics and stuff, there's 100 reasons that it doesn't work. A lot of it is protecting it in the GI tract before it can even get absorbed. And then some of it is even just like, how to get the appropriate amount of dose into something. So it's a really interesting task, and it's a really interesting thing to work on, and definitely something that people would love. So many people prefer to take medications orally daily than to do an injection once a month, which sounds inconvenient, I think, to some people, but most people just feel safer with that oral version. So if that's something you're interested, please go make it happen.
Do you have data on the use of pre or probiotics in infants and whether people have investigated how this might impact drug absorption?
I don't specifically. Trying to think. I don't remember coming across too much of it either. It'd be a good thing to include for the next presentation if it's out there. There's a lot of data looking at pre and probiotics for different disease conditions. A lot of work in things like using it to prevent necrotizing enterocolitis, using them to treat colic. Like everything is out there as far as that. But as far as like specifically how does that affect drug metabolism, drug absorption, I don't know. That's a great question.
Yeah, I would expect it could influence the microbiome in some sort of event and then change that as well. So
yeah, I mean, absolutely. And like what we know about the microbiome interaction with any of this stuff is just so small at this point, that, and a lot of like guesswork, that it makes absolute sense that it would affect that.
And then it's a couple more now. Sepsis is suggested to cause microvilli to invaginate. Do we have quantitative information on drug absorption, and do trophic feeds provide early restoration of normal villi function and drug absorption?
That's a very specific question. So wait, say it again. So I heard do trophic feeds help?
Yeah, do we have any information on drug absorption and whether trophic feeds provide early restoration of normal microvilli function?
Okay, so if I sort of separate that out a little bit, trophic feed, I don't know like the specific numbers. Trophic feeds in general are beneficial to intestines. They are beneficial to intestine growth. They're beneficial to intestine maturation and differentiation as well, if you can swing it. The thing is, in like real life practice, like we would love to be able to even run trophic feeds in every baby, or every short gut kid or whatever. But a lot of times it's not reasonable. They either start dumping food, or they, start having massive amounts of diarrhea, etc. So in general, yes, trophic feeds are great. They're known to be beneficial for enterocytes, but it's so situation specific that I think it's a little bit hard to make sometimes those big broad statements, especially when you're talking about like drug absorption. I don't know. I'd have to look that up to see whether anybody's done any specific studies on that. If you want to, I guarantee the short gut population would love to see things like, okay, how do, in this age, in this, length of intestine, essentially, in this reason for intestinal resection, how well are they, dealing with, how well do they absorb different medications, different nutrient components, and how is that affected by trophic feeds? It's a lot of layers of like stuff that goes into it. So there's probably some stuff out there, but again, it's always so hard to put like that whole picture together because, intestinal absorption is just so complicated.
got to break it down to like little bits.
Right, great. And one more that may again be a more pointed question of a specific area. Are there significant differences in immune response changes among IBD patients during various stages of childhood development?
That's a great question. And so that's a great question. And it's also, I feel like I'm repeating myself, but a little multifactorial. And part of that is that IBD phenotype is really different depending on age in general. So how the disease, like the aggressiveness of the disease, how it presents, what you can expect and how it responds are all very different depending on the age group that you're talking about. So like your classic IBD patient is like a teenager who like a sort of like a mid-teenager, but we have neonatal onset IBD. Those patients are much more likely to have a monogenic cause that's going to respond differently. There's also a lot of studies out there looking at I say a lot, relatively a lot of studies looking at like drug level variations with like infliximab and adalimumab depending on age, disease severity, etc. And this is one of those times when like there's I call it the we know that's like we the clinicians of the world, we know that babies and smaller kids need higher doses of infliximab. We know that neonatal infants, neonatal onset disease, if it's going to respond, is going to need like up to 20 milligrams per kilogram of infliximab. But there's some studies out there. There's not enough though for instance, to convince an insurance company that's the case, because the FDA approved version is 5 milligrams per kilogram. So there's definitely differences in in like that drug exposure and like how that matters and what levels they need in depending on like what their phenotype of disease is. Did that answer the question? I'm not sure.
I think in a way it does. And of course, we need more data on all of this.
I know. I feel like I say it all the time,
right?
but
So we
so
just
hard to be firm.
we know, but we don't know.
Yeah.
So yeah, I think, it's been a very interesting talk. And, I think it does point out that even in addition to the child's age, there's a lot of other disease factors and, comorbid conditions and environmental factors that lead to the variability. And I think we saw that in many of your plots where, yes, even though there's a trend over time, there's a lot of variability in all age groups that needs to be explained as well. So
Yeah.
I thank everyone for hanging on a few extra minutes. And I again apologize for the technical difficulties at the beginning of the webinar. I thank you for joining us today, and especially thank Rachel for a very interesting and informative talk on developmental changes of the digestive tract. So we will see everyone next week. Thank you.
Thank you, everyone.